Hello, everyone. I am Dr. Antonio Avina. I am a research scientist at Arthritis Research Canada, an associate professor of medicine at UBC, the BC Lupus Research Scholar, as well as the Walter and Marlene Booth Research Scholar. Happy that you joined in to the BC Lupus Symposium of 2021. It's an honor to present here, and it's important for the community. I hope that you and your families are safe and enjoying the nice weather, even though we still have some restrictions to follow. Anyway, thank you for joining us today. I am going to give a presentation on the risk of COVID-19 among lupus people in BC and in comparison to the general population. This is the first time this data has been presented. It's extremely fresh. I can still smell cooking, warm, and like chocolate cookie. I hope you enjoyed it. I have no conflict of interest for this presentation. I don't receive payments from industry, and I'm happy for that. To give context to this presentation, I'll review some data on the existing research. As you know, people with systemic autoimmune rheumatic disorders or autoimmune diseases have a higher risk of developing viral infections, as well as bacterial infections. With respect to the COVID-19, there is limited and conflicting evidence regarding the risk and the severity of COVID-19 among these type of population. Similar studies have found that some people may have increased or similar admission rates, deaths, and admissions to ICU than the general population. This has been demonstrated in some studies for rheumatoid arthritis, ankylosing spondylitis, lupus, Sjogren's disease, or GCA, or temporal arthritis disease. However, other studies have found that some people with rheumatic diseases may have an increased risk of severe outcomes, especially hospitalizations, oxygen support, admissions to intensive care units, and even higher mortality compared to people without rheumatic diseases. Other studies have shown that there is decreased risk of hospitalizations, admissions to intensive care unit, mechanical ventilation, etc. Why this discrepancy? This is basically for two main reasons. One could be small sample sizes, and the second, which I think the most important one, is how do you select your control population? If you do not select a control population that represents the general population, the estimates could be overinflated or underinflated. Because remember, you're comparing risk of X, which is lupus, versus Y, and the way you select both, it will define how much risk you could find when you compare both groups. Keep this in mind because this is the big difference from the study that I'm going to present to you today. Again, as a background, the burden of lupus in Canada, it is estimated between 1 and 2 cases for each 1,000 or 2,000 people in Canada. Therefore, the estimated number of cases with lupus has been reported between 12,000 and 19,000 people. I think this is an underestimation. And it is known that North America has one of the highest prevalence of lupus, and among the Canadian provinces, BC has one of the highest prevalence compared to the rest of Canada. Now, what is the burden of COVID-19 in the lupus population? So far, what we know. I'm on a survey done from the World Lupus Federation reported that 10% of people did self-report to have been infected by COVID-19. So 1 in 10. However, most studies that have been reported so far include very small samples. And as I said before, they don't represent the general population. I'm going to give you an example here. You can see that in this study, which recently published, show that among 17 patients with lupus, 13 developed pneumonia, 11 respiratory failure, 5 what is called acute respiratory distress syndrome, or ARDS, 3 acute failure. In another study, it was found that in New York, 4% of people with lupus were reported to being exposed to COVID-19 and having developed the disease versus the 2% from the general population, suggesting that the risk could be double. How about in Canada? We don't have data, and this will be probably the first population-based data. The objectives of this research project that I am presenting to you today was first to assess the risk of COVID-19 infection in patients with lupus compared to the general population. To answer the question, do lupus patients have an increased risk of developing COVID-19? And the second question was, if you develop COVID-19, are you at higher risk of developing adverse outcomes, including hospitalizations, admissions to intensive care unit, or higher mortality in comparison with people without lupus from the general population? To answer these questions, we use the entire population of BC using administrative health data from the province. Just to give you an overview how this research was conducted and why it's so important. In BC, as you know, we have free healthcare. For every healthcare encounter that you, me, or your families get in the province, that creates a record with a diagnostic code that is submitted to the government so the government can pay for the service to physicians, to pharmacies, to hospitals, etc. Investigations for labs. Therefore, we can follow individuals every time they get in touch with the healthcare system using their services. And that allows us to have a trajectory, follow up the trajectory in the healthcare system, eventually from birth to death. The databases include hospital records, dispensed medications, encounters with physicians, investigations, etc. That database, all of those data are collected in the University of British Columbia at PubData, which is called Population Data BC, which is the guardian of the data for the Ministry of Health. You can access to that data to answer research questions, and the beauty of it is their data is rich because you can distinguish sex, age, location, socioeconomic status, if you're an immigrant or not, etc. However, the data has very strict rules to keep anonymous information. So you cannot identify individuals, which is the purpose. But you have access to the entire population of BC. And for this question, we use the entire existing population in BC during 2021. Keep this in mind because this is the big difference with previous studies where they do mostly case series or small cohorts from specific geographical locations rather than the entire population. So for question 1, we use what we call the case control design to answer the question, do people with lupus have an increased risk of developing COVID-19? The case control design, and I want to walk you through so you can understand the importance of the designs, and then you become experts now. The case control is based on cases, meaning those who already developed the outcome, in this case, the infection with COVID. And the controls will be those people who do not have the outcome of interest, which is COVID-19. So cases are COVID-19 positive, controls are people with COVID-19 negative. And then we go back and see how many of those have lupus, which is in this slide, you can see as exposed, or do not have lupus, which is the unexposed. And we do exactly the same in the controls. This design is used when you have rare outcomes because it's effective, efficient, and cheap. And it's a very robust study design. And this is the one we use. We designed this study this way because when we started with the grant at the beginning of the pandemic, we thought that we will have very few cases with lupus and COVID. And therefore, we use this. And we still have few cases, but definitely more than we expected at the beginning, unfortunately. So for this study, we use all the COVID-19 cases existing up until January 12 of 2021, which were 54,000 cases of COVID, and matched them with individuals without COVID from the general population. So for AIM-2, we use a different approach, what we call the cohort study design. For that one, is the opposite. You have already the outcome, which is COVID and lupus, and then you follow them for a certain period of time to see what will be the next outcome of interest, which in this case will be admissions to hospital, admissions to intensive care unit, or mortality. And the same for the control group, which is the match group, is follow prospectively to see if the rates of outcomes is different between the two groups. We do fancy statistical analysis to adjust for potential differences by geographical location, by pre-existing diseases, so you can actually remove the effect of those differences and then attribute the risk only to the disease of interest or the exposure of interest, which in this case is lupus. If you have questions, please write it down and attend the questions sessions that will be hosted on Friday. I said that we had 54,000 cases at the beginning. However, in the last 24 hours, 48 hours before this presentation, we got a new update of the data up until April, and then we rerun all the analysis. So for question 1, the sample size now is 104,000 cases of COVID. Among those, remember, we were looking how many of those had lupus. We found almost 200 cases with COVID that had lupus. And among the controls, which were matched up to 20 individuals from the general population, that means 2 million people without COVID, we identified 2,300 cases with lupus. And then we were looking at the risk. In this case, the risk was 15%, which is 1.15, and the 95 confidence interval is from 0.9 to 1.3. And I want to stop here for a little bit to explain how the 95 confidence intervals happen. When we do comparison on risk, we always assume, and the assumption in general is that the risk is always 1, because the events will happen regardless, right? For example, anybody has a potential risk of dying or getting lupus or getting a heart attack, having the disease or not having the disease. If you think that the disease increases the risk, then the risk has to be higher than 1. And then if you repeat the experiment 100 times, the probability will change. And then you estimate, if you repeat the experiment 100 times, what will be the probability? What will be the lowest value and the highest value? In this case, the lowest value was 0.1, which is below 1. That means includes 1. So therefore, this is not considered statistically significant, because if we repeat the experiment, sometimes the value will be close to 1, which is the expected risk for the general population, and the highest probability will be 33% risk of developing COVID. Okay, so remember, the risk should not include, the 95 confidence interval should not include 1 or lower, meaning that it's not statistically significant. And this is just to give you that what is statistically significant versus what is not. So for AIM-2, the question was, do people with lupus who developed COVID have worse outcomes or better outcomes than people without lupus from the general population after matching by age and sex and pre-existing comorbidities like high blood pressure, hypertension, cardiovascular disease, etc. So We identify 79 individuals with lupus among 54,000 people with COVID. That was from the January 15 cutoff of COVID. And then we follow them. And those were matched almost 1-4 with people without lupus from the general population. And then we follow to see what happened. When we assess the risk, measured with the odds ratio, which in this case is OR, after adjusting for all these variables that I told you, then the risk was double, 2.32. However, remember the 95 confidence interval includes 1 because the lower limit is below 1. So therefore, this is not statistically significant, and this could be a power issue, meaning we do not have enough numbers. But the trend is like there is maybe an increased risk of hospitalizations. Then, if you get admitted to hospital, what is the risk of you developing admissions to intensive care unit? Then the risk was almost 900 times or 9-folds, 9.61, and the 95 confidence intervals here include the lowest probability 2 times and the highest probability 45 times, which is statistically significant. And then what happened with the risk of death? Well, we have, fortunately, very few cases with lupus that died as a consequence of COVID, and therefore, when you have few numbers, it's impossible to estimate the actual risk because it's not accurate. And therefore, we were not able to estimate the risk. Now, I thought that since we're actually having access to vaccines now in BC and in Canada in a higher proportion than before, and there is such a hesitancy, I thought that would be important to discuss or talk a little bit about vaccination. So the question is, should we get vaccinated or not? Well, I'll give you the context of how much vaccines have been applied in the world, just to set up the mind and discuss probably in the question period. To give you a perspective on the impact of this pandemic. Up until May 6th, there has been almost 155 million cases of COVID-19 in the world. And among this, there will be almost 3.2 million deaths globally. Devastating disease in such a short period of time. So, how about in BC? Up until May 6th of this year, we had 132,925 COVID cases and almost 1,600 deaths, unfortunately. So we have achieved, thanks to research and global effort from industry and governments, to develop in a record time vaccines. So to give you a perspective again, globally, there has been administered almost 1.2 billion doses of vaccine. And in Canada, we have administered almost 15.2 million doses of COVID-19 vaccines. And in BC, almost 2 million doses. And I want you to remember this number because what you hear in the media is 3 cases had happened of blood clots in Canada and 12 in Europe among all these number of vaccines. So always bad news make more noise than the good news. So you don't hear about the 16 million people globally or in Canada, I will say, almost 16 million people probably by today or the day you listen to this presentation that have received the vaccine, only for those 2 or 3 cases who had adverse events, serious adverse events. So you're ignoring 13 million people or 14 million people only focus on N3. So please keep this in perspective. So again, just to give you a perspective, the biggest complication that is happening with, especially with the AstraZeneca vaccine, which is the risk of blood clots, which is not exactly like a VTE, which stands for venous thromboembolism, which is blood clots in your legs and your lungs, or your lungs. That happens naturally in other conditions, including the general population who is healthy. So when you want to compare what is the risk in X group versus the Y group. In the Pfizer and Moderna vaccine, we have seen globally has been reported that the risk is 4.1 cases of VTE or venous thromboembolism for every million number of vaccines that you administer. 4.1 in 1 million. This is like winning the lottery. Now, how about cerebral thrombosis, also cerebral VTE? Well, the incidence is 39 per million in people who get COVID. You can compare the number. So which one is higher? Definitely, the risk is higher in people who get COVID infection. So therefore, you are at higher risk of developing venous thromboembolism or blood clots if you develop COVID versus if you don't get the vaccine. And remember, you are at higher risk eventually to develop COVID-19 if you're not vaccinated. So how about in the general population? Well, the same risk has been estimated in European ancestry individuals. The risk of developing blood clots in the legs or lungs is between 100 cases to almost 200 cases for every 100,000 people that you follow for a year. I mean, if you follow 100,000 individuals for 1 year, at some point you will see the risk of 100 thrombotic events or up to almost 200 cases in a year. That is significantly higher than you will see, or that the ones that have been reported for the vaccine group. And the risk varies depending on the population, and that's why it's also important to compare those rates depending on the ethnic background. So it has been reported that the risk of thromboembolism is actually higher in African Americans, lower in Asians, and Asians that are Native Americans. How about a specific risk of embolic events that goes to the lung, which are the severe ones who could lead to mortality over time? Well, the risk of pulmonary embolism, referred here as PE, goes from 30 cases to almost 80 cases for 100,000 person years. Again, if you follow 100,000 individuals for 1 year, eventually you will see that the risk of developing blood clots in the lungs goes from 30 to almost 80, which is significantly higher than the one you would expect in the population vaccinated with COVID-19 vaccines. And the same from the deep venous thrombosis, shown here as DVT. Again, if you follow 100,000 individuals for 1 year, you will see that eventually you will get between 45 cases to 117 cases with blood clots in the legs. The risk is there and it happens, but it's significantly less in people with vaccines and is higher in people who get COVID-19. So in conclusion, people with lupus are not an increased risk of developing COVID-19. There is a trend to have higher rate of hospitalizations compared to the general population. However, this was not statistically significant. And the only high risk for patients with lupus is if you develop COVID, you have 9 times more risk of being admitted to intensive care unit compared to people without lupus who also get COVID. And this is important to keep in mind to assess and decrease the risk of getting COVID through vaccinations. Having said that, I hope I have convinced you, first, that the risk is not higher, but if you get it, the only risk that seems to be increased is admissions to ICU, and therefore you should wait very carefully. To me, it's a no-brainer getting the vaccine. If you don't get your vaccine, then you will have to follow the rules for the rest of your life of wearing face masks, keep yourself with self-distance from others, and you may have restrictions to travel. Remember, there will be individuals in the province who choose not to get the vaccine, and therefore the virus will have potential possibility of still getting infecting people, and you may encounter those individuals. And at some point, 6 months, a year, 2 years, 5 years from now, if you're not vaccinated, you will have the possibility of getting infected with this virus. Therefore, I invite every single patient to get vaccinated as soon as possible, because that will help you, your families, and the society. I would like to finish this presentation with a huge thank to the funding agency who support this research project, which is the Michael Smith Foundation, the VC Support Unit, to funding some of the patient partners in this project, as well as the research team listed here. This is a thank you also for those people who will be participating in a survey that we are going to do to ask important questions for those people who got COVID. And I invite you to stay tuned and engage with us. Please visit our research website to get a sense of where are we doing and where we're going. Thank you very much, and I hope to see you at the question session. I'll be happy to answer all those questions that you may have. Again, hope you are safe and continue being safe. Take care.